Well, good morning, everyone. We have straight up at the top of the hour, we're going to be talking about chronic care management services today. And this webinar is really designed to provide a brief overview of chronic care management and then get to the questions that you have. You'll be able to enter your question into the chat function. You want to enter that, make sure that's going to all panelists. And then Mary Muko, my colleague, will be able to read those off as we get down to the question section. We do not have a handout for this presentation today, since it is a question and answer session. We do have information available for you on our website. We have numerous YouTube videos on the WPS YouTube channel. There is a playlist specifically for chronic care management services. And there's multiple videos in there, including encores or recordings of previous events that we have done. In our Learning Center, you can find a question and answer document. We're up to version 5. So we are continuing to add questions and answers to those questions as we continue on doing education on chronic care management. So the first thing that we're going to do is we're going to find the CMS fact sheet or booklet rather on chronic care management services. Now, the easiest way that I find to actually find this, if you don't already have this bookmarked, is go into the cms.gov website. Under the search function, do a search for care management. And then it is the first one that shows up. Now, as you scroll down through this, you can see that there's a lot of different care management items on here, but we're going to go into the Chronic Care Management Services fact sheet by CMS. This provides the latest information that CMS has available on chronic care management services. Now, we're going to jump around just a little bit within this presentation today, because of the way I want to provide this information. So the first place that we're going to go is on page 6 into the patient eligibility. And I'll try and be careful in scrolling so I don't make anyone dizzy. So what this talks about in this section of the fact sheet is the patients who are actually eligible to receive chronic care management services. And as you can see here, right up here at the top, patients must have multiple 2 or more chronic conditions. They're expected to last at least 12 months or until the patient's death. In addition to that, that chronic condition is going to place them at significant risk of death, acute exacerbation, decompensation, or functional decline. Now, I want to address that sentence here just a minute. It places the patient at significant risk of death, etc. However, the patient does not have to be in crisis in order to receive chronic care management services. So you could have a beneficiary, let's say they have diabetes, they have hypertension. There are patients you're going to have that are in crisis with either one of those diagnoses, and chronic care management, of course, would be effective for them. You could also have patients, though, where their diabetes is controlled, their hypertension is controlled, but that particular diagnosis itself places them at significant risk of death, and the rest of the explanation there. In this listing on page 6 here of your handout, let me scroll down just a little further. It gives you examples of chronic conditions, but these are not all inclusive. These are just examples. You'll evaluate your patient, determine whether or not it is a condition that's expected to last at least 12 months or until the death of the patient. and whether that condition will place them at significant risk. So even if your patient's diagnoses are not on this list, does not mean that the patient is not qualified or eligible to receive these services. Now we're going to go up to page 5. I'm going to scroll up here real quick. And we're going to talk about who is eligible to provide these services. And really we have kind of two different things going on. We have who is eligible to bill for these services, and you can see there MDs or DOs are eligible, non-physician practitioners, and those are listed there for you. Generally speaking, the services are going to be provided by your clinical staff. Now, that doesn't mean that your physicians and practitioners are not going to be providing services. They obviously are going to be providing general supervision over that clinical staff, but they also could provide other services during that particular, during the month for which you're billing for these services. In the so the clinical staff provide the care, generally speaking, and then the physicians and non-physician practitioners are going to be the one who bill for that care. Now, of course, as the provider who's billing for that service, they have to verify that all of the requirements have been met. That's part of their responsibility. We have upcoming webinars for you. I need to scroll down on my page here. We have a webinar coming up on March 16th that is going to be specific for RHCs and FQHCs. We have one coming on April 20th that is going to be specific for services provided by a hospital outpatient department. We are also going to be doing services on, or webinars on, barriers and challenges that we have heard from providers on chronic care management services. And we'll address some of the information that we have received that really shows how you can begin to provide these services. We have a great YouTube video, again, on our YouTube channel under the playlist for chronic care management, where our contractor medical director, Dr. Joelle Bahakas, has really talked about how to begin a chronic care management program if you have not already done that. There are some startup things, that need to happen. You need to identify patients, identify what providers are going to be involved, etc. But once you kind of get over that hump, is the term that she uses within that YouTube video, and you get your workflows in place and your documentation requirements in place, then it's pretty much smooth sailing from there. With chronic care management services, number one, it provides a great benefit to the patients in that it reduces care fragmentation. It provides a way for the patient and the clinical staff to really interact each month so that the clinical staff and the patient are kind of more on top of what's going on with their care. And then it also provides a good benefit for the providers. Number one, in a revenue stream, Medicare has assigned value to these procedure codes and to these services. And so it provides a revenue stream, but it also provides time for your physicians and practitioners. Because this patient is being taken care of through that clinical staff under the general supervision of the physician or non-physician practitioner, that frees up time for your physicians to actually be seeing other patients. It reduces, for your provider community, it reduces some of those more urgently needed evaluation and management services within your offices. It can also free up some time for your clinical staff because they're making contact with that patient on a monthly basis, the patient may not need to call in as much. The next thing that we want to talk about is going to be on page 7 of your handout, and this is information on how you start or what you start looking at for chronic care management services. Number one, if the patient has not been seen ever by your billing practitioner or not seen within the previous year, then you do need to have an initiating visit. Now, that initiating visit can occur during an E&M service, and we had a pre-submitted question on this, whether it could be in the home, whether it could be in a nursing facility, and the answer to that is yes. It's simply an E&M service. It can also be done during the annual wellness visit, the initial preventive physical exam, and what's not mentioned on this fact sheet, but is also true, is that it can be the face-to-face visit under transitional care management. Now you'll notice on here that it says can occur during a comprehensive face-to-face E&M. CMS does not require any specific level of your E&M service, so it is simply a face-to-face E&M service. You'll notice here on your third bullet point that if the practitioner does not discuss CCM, chronic care management, during that initiating visit, then it doesn't count as one. Okay. However, when the patient comes back, or if you determine that the patient needs to have CCM, you don't have to have another visit. The patient is now established with you because they've had an E&M, they've had the welcome to Medicare visit or the annual wellness visit. You'll also notice on there that a face-to-face visit is not part of CCM and can be billed separately. Now you'll notice down here, Medicare has an additional procedure code that can be billed, which is the G0506. And this is a comprehensive assessment and care planning done by the physician or practitioner. So what that means is during that initiating visit, and that's the only time when this is can be billed on the same day as that initiating visit, you're having the conversation with the patient about CCM, and then your practitioner is doing this comprehensive assessment and doing the care plan for the patient. CMS does not assign any time to that procedure code. Documentation would just have to support comprehensive assessment and then the start of the care plan. You'll also notice here on this page, we'll scroll down a little bit, that the patient does have to consent to this service. Now, when we're talking about the patient consent, this is a little different than the normal authorizations that you would have with your patient, where the patient is signing an authorization form to allow you to submit claims to Medicare, to allow you to release information as needed, to allow you to receive that payment back. Those are authorizations that are going to be in your general records within your office. The patient's consent has to go in the medical record. And so that patient's consent can be either written or verbal. It can be gathered by the practitioner. It can be gathered by the clinical staff, either one. And what this consent does is really alert the patient to what's going to be happening with this. So you're going to talk about the availability of the chronic care management services, which is going to include that 24/7 access. The patient can call at 3 o'clock in the morning, and they should be able to talk with clinical staff in order to answer their questions, to address whatever concerns that they have. Chronic care management has cost sharing. The patient's cost sharing is anywhere from about $12, $15 a month, something along those lines, depending on the level of service that you have provided. This is sometimes a little difficult to have this conversation with the patient. One of the things that you want to do, though, in talking about cost sharing is what CCM is designed to do for them, which is to reduce their emergency department visits, to reduce their inpatient hospitalizations. The Medicare cost for a hospitalization, the first one within a benefit period, is $1,600. Well, with a cost sharing of 12 to 15, that pays for a whole lot of months of chronic care management without them having to go in the hospital. So that's part of the conversation that you want to have, the benefit that the patient will be getting for their cost sharing responsibilities. The other thing that you want to have a conversation with on the patient is the fact that only one practitioner can furnish and bill chronic care management during a calendar month. So if the patient has multiple providers that they're seeing, you want to be asking the question, has anyone else had this conversation with you? Does anyone else or has anyone else mentioned to you that they're going to begin billing chronic care management services? Because again, only one can bill. Now, the principal care management, an additional provider or providers can bill for that service. And then you also want to let them know that they have the right to stop CCM when they choose to. And that's going to be at the end of the calendar month. And so what that means is that if you have provided the services to support billing to us for that calendar month, then you can go ahead and submit that. The next thing that we want to look at then is the care plan. And this is on page 8 of the handout. In the comprehensive care plan, this is what needs to be included. And you can see here, it's not limited to this, but these are the items that need to be included. A couple of things that providers have asked questions on is number one, the problem list. Is it only the chronic conditions that need to go in this comprehensive care plan? And the answer to that is no, it's all of the problems that a patient has. So what this means is that you may not necessarily be treating one of the problems, or no one's treating a problem, but that still has to be part of that problem list. Say, for an example, you're treating a patient with diabetes and with hypertension, and the patient has rheumatoid arthritis, and you have someone else who is treating that. As part of this comprehensive care plan, you need to identify that additional problem and then who's treating that, because you will need to have conversations or exchanges of information on that care plan so that it is a comprehensive care plan for that patient. Another question that we receive is talking about cognitive and functional assessment. Well, this is going to be a clinical decision. Do you believe that the patient has any cognitive dysfunction? If so, then you need to do testing. If you don't believe the patient has any cognitive dysfunction, then you'll simply document that. Another thing that's listed there is symptom management. This could be a patient having trouble breathing. It could be a patient in a lot of pain, whatever the situation is. And so as part of the care plan, you want to identify ways to manage those symptoms. Now, this could be things that you want the patient to do. It could be things that you're going to do. It could be things that working with one of the other providers involved in that patient management that you work out together, but that's part of the care plan itself. Medication management is a big issue with the comprehensive care plan. As we're aware, as beneficiaries get older, and of course, Medicare beneficiaries are generally over 65, they have more providers involved in their care. They have more medications that they're receiving, either from the different providers, from a discharge from a hospital, whatever the situation might be. In billing for chronic care management, you are managing their medications. That's their adherence to the instructions for the medications, and then also looking for interactions. Does this medication work with that one? Does this medication cause a side effect that we need to manage? If we change this medication, could we reduce that side effect? So if you're not the only provider who's involved in the patient's care, then again, those are conversations and interactions that you need to have. And then the environmental evaluation is going to be information on social determinants of health. Is their home safe? Do they have a home? Can they get to the good grocery store? Do they have transportation to get to the good grocery store to be able to meet their food needs? Are As part of are they safe in their home is not just the home itself, but also anyone else who may be living there. Do they fear someone who is living in their home? So those are questions that you want to ask. And then you need to evaluate the caregiver. Number one, do they need a caregiver? Number two, if they have one, is that person capable of really assisting them and understanding the instructions that you're providing? Medicare requires at least a yearly review of the care plan. And then, of course, you'll be monitoring, updating that care plan as necessary as you continue your monthly services for the patient. You want to provide a copy of that care plan to the patient. Now, this can be done through handing the patient a paper copy. It could be through loading it into the portal. It's going to be based on the patient, what the patient wants, and then also what you are capable of. For example, if you don't have a portal, obviously you're not going to be loading this to the portal. And so your care plan is going to include not only what you're going to be doing, monitoring medications, looking at lab tests, whatever it is that you need to do for that patient, but also the things you want the patient to do. Under symptom management, we talked about trouble breathing. Okay. So maybe in order to help that person to breathe better, maybe they need to move more. So that will be part of your care plan, where you want to, how much further you want them to move every day. Just depends on what's going on with that patient. And then if we scroll down, again, the patient has to have 24/7 access to physicians or clinical staff so that they can ask questions, they can have their needs met, no matter the time of the day or week. A lot of times when you call into your provider's office, the first message that you receive is, if this is an emergency, hang up and dial 911. For your chronic care management patients, that should not be the first message that they receive. They need to be able to get to that clinical staff. Now, there's all kinds of different ways that you can do that. You can have a clinical staff who's on call. You can be working with a care management organization who's taking those calls. You could be contracted with clinical staff from your local hospital who have access to the care plan, and they're taking your after-hour calls. You can use an answering service as long as your answering service can identify this patient is a CCM patient, and therefore they need to get to that clinical staff. So, the possibilities are kind of wide open how you do that, as long as that patient can get to clinical staff members. The next thing that we want to look at then is on page 10 of the handout, and this is talking about principal care management. Now, a couple of things on this one. You'll notice here it says, um, well, let's start at the top one. Single chronic condition um, for the patient. This is principal care management. Services are the chronic condition is expected to last. This says at least 6 months. It's actually at least 3 months to a year or until the patient's death. And so this is a way for either general practitioners or specialty offices to be part of this care management program and to, again, kind of be concentrating on that patient's care in a proactive rather than a reactive way. Now we're going to scroll down here just a little bit to the procedure code on principal care management. And I want to show you this section right here. Okay, and the condition, it's not just that they have this single chronic condition, but the condition requires either frequent adjustments in the medications or the management of the condition is unusually complex due to comorbidities, ongoing communication, care coordination, etc. So in principal care management, what we're looking at is either the patient has had a hospitalization, and so now we need to stabilize that patient and possibly return them to their primary care physician, or the situation with their chronic condition, it's very complex. There's a lot of medication things going on, or the additional comorbidities make the condition a lot more complex. So when we're talking about CCM, or I'm sorry, principal care management, we're really talking a patient who is possibly more in crisis than we were talking with the CCM services themselves. And then the same rules apply for this procedure code here. You can see it's the first 30 minutes provided by the physician or practitioner. We have each additional 30 minutes. As we scroll down, we get into the additional procedure codes. So pages 10 through 12 in this document have a listing of all of the procedure codes. Rural health clinics and federally qualified health centers can only submit the G0511 procedure code, but they can submit that code and it is paid separately from their all-inclusive rate or their prospective payment system. It is paid under the non-facility rate under the Medicare physician fee schedule. A hospital outpatient can submit the procedure code 99490, which is the clinical staff procedure code for the chronic care management. If we continue on page 13, this just provides you with some summary information. And it basically goes through all of the other things that are contained within this document and simply provides you with some additional information. So we've talked about the fact that we have YouTube videos available for you. We encourage you to take a look at those. I think I saw that Mary had placed the URL or the link to that in the chat function. So this has been just a brief overview of chronic care management. Now, obviously, this has not been all of the information on chronic care management, but just a brief overview. So the next thing that we want to do is we want to take your questions, and Mary will read those questions off. I do have two pre-submitted questions that I want to go ahead and get to before we go into what Mary has for us. The first pre-submitted question talks about that initiating visit. And the specific question was, could it be done in a home? Could it be a home visit or a nursing facility visit? And the answer to both of those is yes. It has to be either the Welcome to Medicare visit, annual wellness visit, the face-to-face time during the transitional care management service, or an E&M. And then the next question that we had, a pre-submitted question, was can we elaborate on the procedure codes 99487 and 99489? Let me go back up in our document so we can get to those. 99487 and 489 are complex chronic care management services. So these two procedure codes, you can see right here, they are clinical staff time under the general supervision of that billing practitioner. So what these two procedure codes, the basic difference between the rest of the CCM codes is the amount of time. You'll notice here that 487 is the first 60 minutes, 489 then is each additional 30 minutes. But the other thing that is part of this is that, let me see it right here. Part of what has to happen is that there is moderate or high complexity medical decision making documented by that billing practitioner. So if that billing practitioner is doing that moderate or high complexity medical decision making, not in an encounter with that patient, then that time can count toward these procedure codes. Now, you can only bill either the clinical codes or the practitioner codes, but your practitioner time can count toward your clinical staff time. Your clinical staff time cannot count toward your practitioner time. But let's say, for an example, the physician or the clinical staff member talks to that billing practitioner and says, you know, hey, we've got something going on with this particular patient. What do we need to do on this? And then your physician is doing a moderate or high complexity medical decision making for that patient. That time can count as part of this 487 code, and then you can bill the complex chronic care management. If they have to have an encounter, an actual E&M with the patient, then they would bill for that E&M service, and then you would document, and that time would not count toward your 60 minutes, but you would document in your care plan, patient had an encounter with doctor on such and such a date. Here is the moderate or high complexity decision making, and then you would identify what that is within your documentation of the care plan itself or the care management service. So those are the two questions that we had received prior to this presentation. So we have scheduled this presentation from until 11:30 Central Time. So we will continue to respond to questions as long as we have questions, or until 11:30, whichever ends first. If we cannot answer all of the questions, Mary will be placing in the chat, and you will receive in your follow-up email how you can ask additional questions so that we can respond to those. So Mary, I'll open it up to you to see if we have.
Hi everyone, this is Mary and Ellen. Yes, we've received some great questions so far. I'm going to start with the first one that was sent in during today's presentation and then move down the list. The first question is, we bill out clinical staff only codes under direction of our resident physicians, but it is billed out under the teaching physician's name on the claim. Who must do the initiating visit where they discuss CCM, the resident or the teaching physician whom we are billing out the CCM under?
Okay, that's a really fantastic question. And what I need to tell you to do is to stop doing that, because your resident, the chronic care management services are not part of the teaching physician guidelines, and they are not under the primary care exception. So let me kind of explain what this means. For services provided by a resident, Medicare can reimburse that teaching physician if they are physically present during the key and critical portions of the service. Well, chronic care management is a timed-based service, which means that the teaching physician would have to be physically there while the resident is doing whatever they're doing. Well, that's not going to happen because, again, these services are generally provided by clinical staff as opposed to by the practitioner themselves. The other way that Medicare can reimburse a teaching physician is under the primary care exception. Under the primary care exception, there are certain procedure codes that the resident can provide, but the teaching physician can receive reimbursement for. Chronic care management is not under the primary care exception. So the resident cannot be the supervising practitioner. It would have to actually be the teaching physician who is supervising the clinical staff. However, residents who are providing part of these chronic care management services, their time can count toward clinical staff time. So if a resident, has an encounter with the patient, they talk to the patient on the phone for 5 minutes, that 5 minutes can count as your clinical staff time. If your resident spends 15 minutes reviewing the lab results and test results from a previous month, that 15 minutes can count as clinical staff time. Under our YouTube playlist for chronic care management, we do have a separate video specifically for services provided by a resident. So I would encourage you to go watch that. A resident cannot be the physician, so they can't supervise the service. They can be clinical staff, or their time can count toward clinical staff in choosing the amount of time that you have submitted. Thank you, Mary. I also want to let you know that our contractor medical director, Dr. Joelle Blahakas, has joined our webinar. And so if it's a clinical question or a question that I can't answer, then I will certainly ask her to weigh in on that also. Mary, back to you.
Thanks, Ellen. And if you've already addressed this, please let me know. I was busy responding to the chat, so I couldn't listen 100% to what you said, but that same question has a second part. If the patient gets a new resident, but teaching physician stays the same, do we have to get a new initiating visit and consent?
You do not, because again, you cannot provide CCM services under the supervision of the resident. The resident is not the billing practitioner. The supervision has to be provided by that MD or DO or the non-physician practitioner. Next question.
Perfect, thanks. Is it okay to bill for the full month of services on the last day of the month? Our providers make calls throughout the month and document the different dates, but I think I can use the last day of the month as the date of service. Is this correct?
This is absolutely correct. And as a matter of fact, this is a best practice. If you're submitting, well, let me go this route. CCM is a monthly service. So number one, we're not going to pay if we have less than 30 days, other than February, but less than 30 days in between services. But it is a whole month. So the best practice is to submit your charges at the end of the month so that you can gather up all of the time that you have spent. In addition to that, you will be able to determine whether or not you have provided a complex chronic care management in addition to the normal chronic care management services. So what we mean by that is, number one, you can't bill both. You wouldn't bill the 99490 as an example and a 99487 in the same month. But what you would do if you have that moderate or high complexity medical decision making during the month, you would move that time that you have already spent into that procedure code. And if you hit that 60 minutes, then you can bill the 99487 rather than the 99490. And as a matter of fact, this is one of our biggest reasons for denials is that we were getting both the 99490 and the 99487 in the same month. And then, of course, Medicare had to deny the second one. Thank you for the question.
Lynn, this is Dr. Vlahakis. Can I weigh in here as well?
Sure.
So one other way to think about complex care management in terms of medical decision making is what kind of medical decision making did the physician need to do at one of the last visits? If it was complex medical decision making and the clinical teams helping to, I'll say, execute that care plan, then it certainly fits in with complex chronic care management. It doesn't necessarily mean that there has to be high-level medical decision at every call if you're simply following what the physician's care plan has dictated.
Hey, thank you, Dr. Balhakis.
All right, Alan, our next question is a very brief one. Is there a template for the CCM consent?
No, there isn't a template. You can basically use just something that says the patient has agreed to accept and receive chronic care management services. The consent, again, can be written or verbal. So if you're having that conversation with the patient and they say, yes, I want to have this, you can just notate that within your files. Medicare does not require any particular format for that.
All right, next question. Is the cost sharing amount generally covered by a beneficiary's supplemental coverage?
Generally speaking, yes. Now, we can't obviously, talk about what other payers may do, but this is a covered Medicare service. So if they have a Medicare supplemental plan, I would expect that they would pay the coinsurance for that. Medicaid would pay the coinsurance for that under the Medicaid rules for your particular state. To my knowledge, we've not heard anyone express anything different than that they were having trouble with with their Medicare supplemental plans.
All right, thank you. Next question, would specialists be able to bill for PCM for the work being done before their scheduled surgery is completed, such as coordinating education classes and appointment setup?
I would really be just a little careful with this one. Let me scroll up on our document here. I don't want to, because look at the definition of principal care management. It is a chronic condition, complex chronic condition, expected to last at least 3 months to a year or until the patient's death. So really you want to be kind of looking at what it is you're doing. Are the services that you're providing really part of Medicare's reimbursement for that surgical procedure? If you do the surgical procedure does the patient no longer have the particular condition? It really is going to be based on your documentation. In the example that you have given, with providing education on the type of surgery, um, providing a class for the patient, and the one that comes to mind for that one would be possibly bariatric surgeries. I would look at your documentation and look at what the rules here say, um, and kind of depending on what it is you're really doing, do you have a care plan that you've done? Does it meet the care plan guidelines? How much time are you spending on that patient, et cetera? Then that would make your determination as to whether or not you could submit the PCM service.
All right, on to the next question. What is the responsibility of the office regarding the patient's technology, accessibility, and knowledge? Do you need to be sure the patient knows and understands about accessing the portal for a copy of their care plan? Many seniors don't necessarily understand what and how to do this, and yet some of the more modern offices put the onus on the patient to figure it out, telling them to just go to the website.
The patient has to have access and have the care plan. So if you're talking to a beneficiary or to a patient and they're saying, I don't know how to get onto the portal, I don't know how to do that, then putting it in the portal is not satisfying the requirements that we have for chronic care management services. You want to be handing a copy of that to the patient, or you want to be doing the education to help the patient to access that portal. Talk to a caregiver, see if there's a family member involved who can help them with that. Because if and a lot of times using the portal is going to be easier for your offices to update, all of that kind of stuff. But if your patient can't get to it, then you don't meet the requirements.
Somewhat related to that, Ellen, there's a question asking if a provider office is required to have a patient portal to provide these services.
No, they are not. That's obviously your choice, your business decision. If you have a portal, you can, use it for this. If you don't have one, then you simply hand the patient a copy of the care plan, paper copy right in their hands.
Thanks. The next question, can enrollment take place on a call with a prior visit without CCM services being mentioned in those office notes?
Yes. As part of chronic care management, if you are not in a situation where you have to have an initiating visit, so in the example that you've given, they saw the patient last month or 3 months ago, you have determined through data analysis in your office, through looking at patients' medical records, I think Dr. Vahakas has used the term high maintenance patients or frequent flyers, those patients who are calling your office a lot. So you've decided that CCM, you're going to start doing this and you're going to start with the patient Susie first. If you have seen Susie within the previous year, then you simply start. Your physician can be involved in developing the care plan, or your clinical staff can develop that care plan. You need to have that consent from the patient, again, either written or verbal. And then your physician or practitioner is providing that general supervision over the clinical staff doing that service.
All right, next question. Can you please define clinical staff? Who falls under that definition?
Clinical staff, the best definition that we have found is actually available on the AAPC website. Let me see if I have that. Okay, I don't have that in my notes here. I'll see if I can get to that just in a minute without losing everybody. But basically, these are people who are either through license, through regulations, facility requirements, able to provide clinical judgment on whatever is happening with that particular patient. So they can evaluate, what a blood pressure looks like, or what a EEG, kind of report looks like, and what we need to do with that. But it is more than ancillary staff, more than medical assistants, unless they have received additional training. So it's going to be licensed, it's going to be based on state regulations, and then what the facility, and what we're using with facility is your practice or your office, what you have determined that person can do within the licensure and the state requirements for your particular office.
All right, next question. Is there a limit to how many times you can bill code 99489 per month?
Let me get down to 99489. As far as I am aware, I don't think there's any medically unlikely edits on the 99489 procedure code. I do not know that for sure, however. I don't know if there's editing built into this. However, as long as you have your documentation to support that you have spent, at this point, we're at 90 minutes, 90 minutes or more with that patient, then Medicare should be able to allow that. Just a reminder also, for the times that are listed within these procedure codes, it is the full time that's listed. So for an example, the 99487 is the first 60 minutes. It has to be 60 minutes. The 99489, you cannot bill that procedure code until you hit 90 minutes. And then, of course, for multiples, you would go up from there.
Thank you. Next question. In the code descriptor for 99487, it states that there is a moderate or high complexity medical decision making. Since this code is for the clinical staff time, who and how is this MDM happening and when?
Well, the moderate or high complexity medical decision making can only be done by the practitioner. So that's going to be your MD or your DO or your non-physician practitioner. Your clinical staff is not going to be making the medical decision, especially at this level, for that particular patient. We would expect to see that this moderate or high complexity medical decision making would be done within the month that you are billing for this service. However, as Dr. Vlahakis talked about, if you are implementing, and Dr. Vlahakis, correct me if I misunderstood, but if this month you are implementing the moderate or high complexity decision making from last month, then this code would still be appropriate. Did I understand you correctly, Dr. Vlahakis?
I think the best way to think about this is that if your clinical staff is executing the plan that required high-level complex medical decision-making, for example, a patient who has been discharged from the hospital, that could qualify a patient who requires frequent visits, and don't forget, a patient, for example, who requires some time from the physician to oversee clinical decision-making, but perhaps it doesn't meet the threshold for time. That might be someone where you're billing for clinical staff time, but you consider it complex.
Thank you, Dr. Vlahakis. Mary, next question.
Sure. If I spend 30 minutes speaking with a patient on January 30 and then follow up with them on February 2, I would not be reimbursed for this? Question.
No, you could be reimbursed for that, but you have, this is a monthly service. So you have 30 minutes that you have spent on chronic care management, I'm assuming, in January. And then you have whatever time you listed, 10 minutes for the start of February. Mary, read the question to me again. Did I misunderstand that?
The question is, if I spend 30 minutes speaking with a patient on January 30 and then follow up with them on February 2nd, would I be reimbursed for this?
The time in February is going to count toward February's chronic care management service. The time in January is going to count toward January's chronic care management service.
Right, on to the next question. Can the care plan be developed by clinical staff, or does the billing provider have to develop the comprehensive care plan?
That's a very good question. And the clinical staff can develop that care plan. They would use the information within the patient's medical records. They would be under the general supervision of that billing practitioner. And so what we mean by that is if they need to check in with that billing practitioner to determine any aspect of the care plan, then they would certainly do that. But no, a clinical staff member can develop that care plan.
Right, and Ellen, I did move out to the AAPC's website, and I placed the link to that website or to the blog question in the chat, but I'd like to read that clinical staff member definition since you don't have access to that right now because you're sharing. It says, a clinical staff member is a person who works under the supervision of a physician or other qualified health care professional and who is allowed by law, regulation, and facility policy to perform or assist in the performance of a specified professional service, but who does not individually report that professional services. Other policies may also affect who may report specific services. So just that answer to that question and providing that information for you. It is available in the link that I posted in the chat. On to the next question though for you, Ellen. Can G05, 06, and 99490 be billed in the same month?
Yes, they can, because you're doing two different services there. You're providing that initiating visit because that G0506 is only billed on the same day as that initiating visit. And then you could be providing an additional 20 minutes of clinical staff time. So the answer is yes.
Thanks, Ellen. Next is, how do we sell this to patients when they have already been receiving this, really services above and beyond coordinating care from their provider, especially if they have an Advantage plan where they would be responsible for the cost sharing responsibility?
Okay, well, we can't address anything with Medicare Advantage, obviously, because we don't represent them. Um, and I'll let Dr. Vlahakis weigh in on this one also, but it really is the conversation that you have with that patient, how excited you are to be offering this service to them. And it is a little bit of a change because they've been able to pick up the phone and call your nursing staff, but you want to present this as a proactive, holistic approach. Really kind of almost a concierge service, to them, that you're going to be interacting with them every month. And here's what we're going to do. And here's, how you have the additional access. And we're really going to try and, keep you from having to go to the emergency room. Nobody likes to sit in an emergency room for 4 or 5 hours if you can prevent that. We're going to work to keep you out of the hospital so you don't have those hospital costs, that go along with that. Not only that $1,600 that's the Medicare deductible, but also those incidental services that Medicare doesn't pay for. Dr. Vlahakis, do you want to weigh in on this one?
I have always believed in primary care that there's a certain degree of salesmanship that does go along with running a primary care practice or even a specialty practice. Um, anytime I explained to someone they needed to go on any hypertensives, it was a discussion. No one likes to go on medications either. But we're always looking towards those goals. And I think just as you mentioned, Ellen, aligning your goals with the goals of the patient, I think sometimes it's really, you can get very specific about the pets that they have at home, the things that they don't want to miss out on. As you mentioned, the pure disruptions of those hospitalizations and emergency department visits. If they've not had those in the past, then talk about how some of the patients that you know with their same conditions often start to run into them at this time, and you really don't want that for them. Sometimes it's a discussion that has to happen over more than one visit. That's not a failure. That's just how our human interactions work. That's how our brains make decisions. I also find it's really helpful if you have a success story to share, something where someone has reflected back to you that the program has worked well for them. And I will share with you when we talk with um, uh, practices that have been able to launch this successfully, and it is a hump, takes a little bit of time. The patients are the ones who benefit the absolute most. The providers do enjoy practicing a different kind of medicine and having more time for face-to-face with patients and less time managing crises in the back, that's for certain. But patients also really appreciate the opportunities to forge relationships with the clinical staff, to feel that they're connected to that physician in a real and meaningful way, that they get answers to their questions. There's nothing like an unsolicited phone call, something the patient didn't have to work hard to get, to make someone feel important. And people really do respond to that. I would say for most folks, once they've been in the program, probably not even a few months, probably a few weeks, they start to understand its benefits.
Thank you, Dr. Vahakas. We appreciate that.
All right, Ellen, back to you. Our next question. If a patient is receiving CCM services during the month and then is admitted to the hospital and remains hospitalized through the end of the month, can we still bill for the CCM services?
You can still bill for the CCM services. This is one of those little weird things that go along with computer systems and processing. If the patient is actually in the hospital on the last day of the month, don't use that as your data service. It will hit up against that hospitalization and say, the patient was in the hospital and therefore they should not be having outpatient services. What you want to do in that situation is simply back your service date up to when you completed whatever time it is for your patient. So it is billable. You may have to move that data service.
All right, thanks. The next question is, for the 99487 code, with it being moderate to high complexity medical decision making, does the care plan need to be created by the billing practitioner? One of the questions on page 2 of the August 2022 document says it's not able to be delegated to any other person, including oversight, management, collaborations, and reassessment elements. Can you explain what this means?
Okay, what this means is that basically that the moderate or high complexity decision making cannot be delegated to that clinical staff. So while the clinical staff, can provide chronic care management services, when we're talking about the 99487 code and 489 procedure code, that moderate or high complexity decision making is made by your billing practitioner. So they're the ones who are looking at the problems and the data and the risk to the patient of whatever medical decision making that they're doing. More than likely, although not necessarily required, but more than likely, there is going to be an adjustment or an emphasis on something within that care plan itself. So what you'll be doing is based on that medical decision making made by that practitioner. And again, that does not have to be in a separate encounter, although it could be, because you can have an evaluation and management service during the same month that you're billing for chronic care management or principal care management. You just want to keep your time and your services separate, obviously. Um, but in the care plan, you're going to document this is the moderate or high complexity decision making that was made. It was made by nurse practitioner Betty, by Dr. Smith, whatever the case might be. And then you'll show any adjustments or any changes, if you have made any, to that care plan and to the services that you're providing to that patient.
Thanks. Next question also has to do with the care plan. If the patient has had a visit within the year, that the clinical staff could write the comprehensive care plan. Did you say that, Ellen? Did you say that if the patient has had a visit within the year, that the clinical staff could write the comprehensive care plan with the physician providing general supervision, or would the physician have to approve the care plan? What we're talking about here is in the documentation, of course.
Sure. And no, the clinical staff can write the care plan. That's part of the reduction of the burden on the physician or non-physician practitioner. That's part of the service. Um, the clinical staff can use the patient's medical records, both the internal records that they have, records from other practitioners who are involved in the patient's care, and then under that general supervision of that billing provider, they can write the care plan. We would not require the physician or practitioner to sign off on the care plan. However, that physician or practitioner needs to understand that since they're billing for the service, they're responsible for whatever their clinical staff have done. So if you have, if your doctor, um, believes that the clinical staff for this patient can write the care plan, I don't need to sign off on it. I don't necessarily need to look at it, before it's implemented. Then as long as it meets that general supervision, then yes, the clinical staff can write the care plan. A lot of words to say yes. Sorry.
All right, thanks, Ellen. Next, can you elaborate on something you said? You can't report complex CCM and prolonged evaluation and management services in the same calendar month. Which codes can be billed in conjunction with a standard 15-minute or 99213 appointment?
Well, when you're submitting charges for chronic care management or principal care management during a month, you cannot also submit any prolonged care services. What you want to do is, for an example, you go in today, and of course, a prolonged care service would not go with a 99213. It can only go with a 99215 to begin with. But if you have that additional time that you're spending on this encounter today, that time would go into your chronic care management service, because that's going to be part of either updating the care plan, implementing, revising, monitoring that care plan for that patient during that month.
All right, thanks, Ellen. Here's the last question that I have at this time. Can clinical staff initiate calls to the patient to check in, or are only patient-initiated discussions counted towards time spent?
Oh, heavens, no. Um, this is where chronic care management, that umbrella, which includes chronic care management complex, chronic care management, and principal care management, this is physician initiated. So you could, with one of your patients, you could make an appointment that we're going to call you every Tuesday. and we're going to call you at 11 o'clock on Tuesday, and we're going to check in with you and, see how we're doing based on the care plan, see any additional symptoms, any, have a conversation about medication adherence, whatever. Another patient, you could say, we're going to call you the first Tuesday of every month at 11 o'clock, and here's what we're going to do. So no, this is not patient initiated, any type of contact that you have. This is provider initiated.
All right, we do have a couple of more questions, a few more that are coming in, Ellen, and we do have some time left. Is G0506 required to be billed at some point of the patient being on this program?
No, it isn't. It is not required. One of the kind of confusions we have seen in the community is that the G0506 is kind of starting chronic care management, and that's not the case. The G0506 is only applicable when you are doing an initiating visit. So you've never seen the patient before, or you've not seen them within the last year. And so today you're seeing them, you're having a conversation on CCM, and as part of that, your physician or practitioner is doing a comprehensive assessment of that patient, and they are doing the care plan. So they are developing the care plan as part of that code. So if for an example, you have seen the patient within the last year and you're going to start CCM and your clinical staff are developing that care plan, working under the general supervision of that practitioner, you don't have to have a new encounter and you don't have the G0506 procedure code. Another myth that's kind of out there is that the G0506 would be billed yearly, and that's not the case. Again, it's only with that initiating visit and only if you're doing the comprehensive assessment and care planning.
All right, thank you. Next question. Can the initiating visit be billed under telehealth for CCM, these services?
If it's a valid telehealth service, yes, it can. And of course, all of the evaluation and management services are valid for telehealth. So if that's how you hold that initiating visit, then that counts as an initiating visit.
Thank you. Next question. Will there be a transcription on this webinar?
There won't be a transcription of the webinar. We are recording this, so we will place this on our YouTube channel as an encore presentation, and it'll be out there for a while. I'm not for sure of the dates that we're going to bring this down. But the other thing that we will be doing is we are also recording the information that has been in the chat. And so we will be updating the current Q&A document, which is version 5. We'll be updating that to a new version that will include all of the questions and answers that we have provided for you here today.
All right. And the last question that I have, at least at this time, is a comment from Jill. CMS has stated that clinical staff is defined by CPT. And Ellen, during the call today, you referenced the AAPC's definition. Is this a change?
No, it's not a change, and to be real honest, I have seen the where CMS has said it is defined by CPT. In the particular version of the CPT book that we have access to, I can't find that definition. So based on everything that we know, what is in the AAPC listing, which is what I can find, is the same as what's in the CPT, but evidently it's in a different version of the CPT than what we have. As a matter of fact, I looked at that again this morning before we started this webinar to see if I could find it in the CPT, and I simply can't find it.
Ellen, that is all the questions I have at this time.
Okay. Um, just a couple of things then, as reminders before we kind of jump off for today. There are things that have to be recorded in a certified electronic health record technology. Let me scroll back up here real quick and get to that section. Okay, you'll notice here when we're talking about the care plan, um, the things that have to be as part of that certified electronic health record technology has to be the patient demographics, the problems, and medications and medication allergies. The rest of your care plan does have to be electronic so that depending on um, how you provide these services, whether it's your internal clinical staff, it's a care management organization, it's a hospital staff that you're contracted with, they have to have um, electronic access to that particular care plan so that it can be shared back and forth. Um, let's see here. I'm looking at the last. Okay, another question that we've received, which I thought was really interesting. We've talked about that chronic care management, those services are generally non-face-to-face services. And so, this is not only having a contact with the patient, but then again, implementing, revising, monitoring the care plan. All of that time goes into that. So one of the questions I found interesting was, well, can face-to-face time go into chronic care management? And the example that the person gave to us was the patient was really more comfortable in coming into the office to have their blood pressure checked as opposed to checking it at home. And if that's a decision that your office makes, that you either want the patient to come in to have the blood pressure check, or the patient wants to come in to have the blood pressure check or weight check or whatever is happening, then yes, that time is still part of chronic care management. Now, you wouldn't bill an E&M service for that, because it would be part of chronic care management, but the time that you're spending in having that face-to-face interaction with the patient can still be part of your monthly chronic care management service. Okay, Mary, any other questions?
None at this time, Ellen. Thank you.
Okay. Well, we want to thank you very much for attending today. Lots of really good questions. Again, we're going to use those to develop that Q&A document, to develop further education. You want to watch our listserv. Again, right now, the webinar for RHCs and FQHCs is advertised. We should have the one for hospital outpatient departments advertised within the next week, probably. And then the next one after that will be Dr. Vahakas talking to us about barriers and challenges. And part of that will be identifying barriers that providers have told us about, and then also identifying how to overcome those barriers through other conversations that we have had with providers who are successfully providing these services. Again, their patients are thrilled to death to be receiving them. And then, of course, Medicare assigns value to this, so they're also receiving reimbursement from that. And then after that, I think we're going to do a CCM overview again, kind of going into all of the nuances of the program. The other thing I want to let you know about is that we're very interested in partnering with your organizations, with your local medical societies, um, state medical societies, etc., to provide this information. So if you have a partnering opportunity for us on our website, and I think Mary has placed that in the chat function a couple of times, but it's the WPSGHA.com. Choose your state, go into the topic center, and then choose training. And we have a form that you can complete and send in to us where we would be able to partner with you. If you represent a teaching hospital and you have provider-based physicians who want to do this service, you have your hospital clinical staff that you want to be involved in this service, the hospital outpatient department can bill for this in addition to the practitioner. That's a good starting point to help you reduce readmissions for the patient, et cetera. So if you want to talk to us about partnering, we would be more than happy to do that. So Mary, I'll ask just once more, do we have any other questions?
We do not, and I'm just placing the link to the partner webpage. We want to partner with you out in the chat box right now.
All right, thank you. The next thing that's going to happen as soon as we end this webinar is you will be taken to a landing page. Now it's going to look a little weird. It'll have kind of a yellow triangle on it, but it is a link to a survey for this particular webinar. We strongly encourage you to complete that survey. It only takes a few minutes. There's not a whole lot of information in there, but we're very interested in your feedback on your opinion about this webinar today. We use this for reporting to CMS. We use this to gather additional topics that you want to see us provide education on. And then just personally, we use this information to improve our webinars going forward. So if you think the webinar was fantastic, please tell us that. If you think there are things that we can do to improve, then please provide that information also. WPS just wants to thank you very much for your attendance, and that will end our webinar for today. Thank you, everyone.